Welcome to Physio Alchemy. In today's video, we'll be talking about the shoulder x-rays, points that we need to keep in mind while looking at shoulder x-rays, exploring various views, pinpointing key structures and landmarks to look out for in your x-ray analysis. Here on the right hand side, I have mentioned few points like soft tissue, periosteal line, identification of bones. We should keep looking these points while analyzing our shoulder x-ray from the very first. So now let us talk about the soft tissue part. Here I am marking the lateral aspect of the arm, and this is the soft tissue area that we are going to look at. These are always grayish in color. If you find any dark black colored structures or boundaries in this area, there can be an injury to either humeral head or the scapular region. We are also going to look at the intercostal spaces and the border of SCM and upper trapezius, and also the supraspinatus muscle. Now moving towards the periosteal line or the cortical line. Always go through the cortical line one by one to each bone, because most of the fractures you will get on these cortical lines. Mark each and every bone, like here I am marking the clavicle, then the lateral border of the scapula to the glenoid cavity, and then the coracoid process. Next, I'm marking the acromion process and the spine of scapula. Now, identification of bones. This is very much important to identify each and every bone and their anatomy. The coracoid process, the glenoid cavity, and the humeral head. And this is the shaft of humerus. Also, do not forget to mark the border of the scapula bone. And the last but not the least, we will be marking each ribs over the shoulder x-ray. Let us now look at the line of the clavicle and the acromion. The lower border of the clavicle should be marked like this while ruling out an x-ray, and this line should match the lower border of the acromion process. If you see a translation superior or inferior, we can say that this superior translation or the inferior translation clearly signs that there can be an injury to this area. Now let us discuss the distance between the clavicle and the coracoid process. So from point this to point this, there should be a distance of at least 13 mm or less than 13 mm. Anything goes beyond this is a sign of injury. And by this, we can rule out that this increase in the distance between these points is a clear sign of dislocation. And moreover, this can say that we have an injury on this side, or there can be a muscular pull such as SCM pulls the clavicle towards itself. Let us now discuss about the distance between the acromion and the clavicle. Here, point A to B, that is the distance between the clavicle and the acromion process, must be 8 mm or less than 8 mm. Anything goes beyond this is a sign of injury or disruption of the acromioclavicular ligaments. On the right hand side, I am putting these points for your reference. This should be 13 mm or less, and the distance between the acromion and clavicle should be 8 mm or less than 8 mm. Now, moving towards the next topic, that is head of humerus. A cane head, that means the head of humerus should look like a head of a cane or a stick. It should not be like this. It should be like a cane. Also, if you see this kind of aperture on a humeral head, that means there is something wrong with the humeral head. Again, marking the cortical line this is a perfect cane shape. If you see this kind of aperture, that means it has a classical case of dislocation, or the humerus has gone into some kind of torsion. Moving on to the different kind of views of a shoulder X-ray. Here we are looking at an axial view or the trauma view. So what are the points that you should keep in mind while looking at axial view? That always go through the cortical line of the humeral head and each bone. It is very important to go with the cortical line. Again, I am marking the clavicle. Now mark the superior part of the glenoid cavity as point A and the inferior part as point B. Join a line between them and make a triangle like this. Now through the triangle bisect a line towards the humeral head, and this point should come between the center part of the humeral head. Again, I am showing you on the right hand side point A and point B. Join them, make a triangle and bisect the triangle towards the center of humeral head. Again, making a triangle and now bisecting this. So this must be the center of the humeral head, but if unfortunately this bisecting line does not go to the center of the humerus and it looks like somewhat this dotted line, that means the below line is the clear sign of anterior dislocation of the humeral head in respect to the glenoid cavity. Or if the line goes like this, that means this is a posterior dislocation of the humeral head over the glenoid cavity. Now again, I'm marking the 2 points for this X-ray. I created a triangle. Now I'm bisecting this. So you can see the center of the humeral head is bisecting by that line, and this dotted line is of no use here. That means there is no dislocation on this shoulder X-ray. Now let us look at the another view of the shoulder X-ray, that is Y view or the scapular view. It holds a great importance while talking about the Y view because this scapular view enhances the shoulder evaluation by capturing scapular specific pathologies often missed on a standard X-rays. This also shows the relation of the humeral head with the scapula and identifies the scapular injury. This also helps in determining the type of dislocation while just seeing this X-ray. Now this is the acromion process and this is the coracoid process. Now I'm marking the clavicle and this is the cortical line of the humerus. Now for the Y view, start marking the point A on the acromion, point B on the coracoid and the point C on the spine of scapula, inferior border of the scapula. Now join these lines and you will see a great view, that is the Y view. This intersecting point must be at the center of the humeral head, and this shows the relation of the humeral head. As you can see, I'm marking the humeral head. And this is coming exactly at the midpoint of the 3 points. Now if you see that midpoint is shifted anteriorly or posteriorly, we can easily rule out dislocations. I hope you understand the importance of Y view. Now let us look at the example. So this is a AP view on the left side and this is a Y view on the right side. Both the X-rays are of the same person on the same time. But as you can see on an axial view or AP view, this humeral head looks perfectly fine, but the shape of the humeral head is not like a cane. So we should always ask about a Y view. And on the Y view, you can clearly see how the humeral head is looking like a cane and it is somewhat shifted from the center point. You can see it is posteriorly dislocated. So again, let us now mark those points. Starting from the point A and point B and point C. This is a Y intersecting these lines, and you can see the humeral head is far more than the actual midpoint of the Y. So we can clearly say that this humeral head is dislocated posteriorly in respect to the glenoid cavity. Now, just for an example, again making this Y, and if the center of the humerus, not the Y, is shifted anteriorly or posteriorly, so you can say this is a posterior dislocation and this is a anterior dislocation. Let us talk about the two important pathologies, that is Hill-Schack lesion and the Bunkert lesion. So starting from soft tissue, we are going towards the bone. We are marking each bone: acromion, clavicle, coracoid process. This is your glenoid cavity. And this is your humeral head. Here we can clearly see that the humeral head is anteriorly dislocated, and while moving through the cortical line of the humerus, we can see there is a dent over the superior surface, and this superior surface is created by the dislocation of the humeral head. Now this is the Hill-Schack lesion. So when this humeral head is anteriorly dislocated, this surface collides with the inferior border of the glenoid cavity. Similarly, on this Y view, you can see how the humeral head is anteriorly dislocated and how it is shifted from the center of the point. Again, while marking the cortical line, you can see a clear dent on the superior surface. This is a Hill-Schack. Now let us talk about the Bunkert lesion. Bunkert lesion is formed when the humeral head is reallocated to the glenoid cavity. So this is the humeral head, and when we reallocate this humeral head to the glenoid cavity, the bony Bunkert forms in the anterior inferior surface of the glenoid cavity. On the other X-ray, while moving through the cortical line, you can see there's a Hill-Schack. Now I'm marking the glenoid cavity, and there is a small fragment on the inferior surface. This small fragment is the bony Bunkert lesion. Again, marking the cortical line, this aperture is a bony Bunkert. On a normal X-ray, the glenoid cavity cortical line looks like this, a clear surface. There should be no bony fragment like we can see here. So while reallocating the humeral head, this posterior surface collides with the inferior surface of the glenoid cavity, and this creates this bony Bunkert. And that is why I was telling you to always move with the cortical line of each bone to rule out the fractures and different kind of lesions. Now let us talk about the greater tuberosity fracture. So we'll start looking at the left hand side X-ray. Starting from the outermost area, that is the soft tissue, you can clearly see there's a swelling in this area. So there might be an injury. So now we will move with the cortical line. So always check the cortical line. So let us start drawing the cortical line here. You can see there's a small breach here indicating a small hairline fracture of the greater tuberosity. Although the humeral head looks like a cane, but still we got a fracture on the outermost area of the humeral head. Now after zooming into the X-ray, we can now draw the entire border of this fractured fragment of the greater tuberosity. Now let us move on the right side. X-rays. We have 3 X-rays here. First we are drawing a cortical line, and you can clearly see that there's a fragment over here of the greater tuberosity which is being pulled medially towards the midline of the body like this. This happens because of the strong muscular pull of the supraspinatus. So here this is the humeral head, this is the greater trochanter area and insertion of the supraspinatus. So whenever this fracture happens, the supraspinatus muscle pulls the fragment towards itself. Always correlate your X-rays with the physical mechanism of injury to the patient while listening to their chief complaints, and you will notice that there is always an inferior blow towards the humeral head, that a strong force coming from the downside towards the humeral head, and that is why the GT, the greater tuberosity, comes in contact with the bony part, and which causes a GT fracture, and then the fracture fragment is pulled by the supraspinatus. So there is a strong force coming from the downside, and here the collision happens at this area, and this will cause the fracture. Now let us look at the second X-ray, which is a type 2 kind of injury, the greater tuberosity. Here, moving with the cortical line, we can clearly see that there is a large breach in the greater tuberosity, and here it is a large fragment of the fracture. Let us now move on to the last X-ray. Now drawing the cortical line, you can see there is a large fracture over the posterior surface, but still fragment is not visible because it is being displaced inferiorly and posterior to the head of humerus. So thank you for watching this video. We'll see you in the next lecture.